I thank you, Dr. Hübner, for the invitation. And pathophysiology of male urinary incontinence, it's a very hot topic because we really don't know very well why some patients develop incontinence. These are my disclosures. These are the place where I work. And incontinence in the male becomes important because of the prostate cancer. Prostate cancer, it's more common. And as men get older, and all the men gets older, even this handsome men, like here, like Dr. Hübner, they will have more chance to have a prostate cancer. And the surgery for prostate cancers in the past was a nightmare. Almost all the patients become incontinent or impotent. And we had some nice research, mainly from Dr. Walsh and Dr. Lu. They described very well the prostate anatomy, and they improved the surgical results. However, many new surgeons are doing prostatectomies, and the amount of operated patients increase year after year. So in terms of the number of patients suffering from incontinence increases a lot. And there are some reasons for patients to develop incontinence after the surgery. For example, the loss of the continuity of vesicourethral muscles, changes in the bladder neck, changes in the fascias and ligaments, lesion in the bladder bases in sympathetic innervation, lesion of urethral junction, changes in the blood supply to the sphincter, change in the size of the sphincter, and changes in the innervation of the sphincter. We know that these factors are involved in the pathophysiology. But why men underwent to radical prostatectomy, why they become incontinent? The majority of them is due to a problem in the sphincter. And this can be alone or associated with bladder hyperactivity. Is that possible to predict these patients? The answer in terms of urodynamics is no. We had showed a paper in this meeting that maybe pelvic floor muscle strength can be a predictor, but not urodynamic. In summary, the incontinence depends on many factors, depends on the sphincter, depends on the detrusor, and the fibrosis. In terms of sphincter, we have many mechanisms: mucosal seal, fibroelastic tissue, isthmus muscle, striated muscle, and pelvic muscle. In terms of supports, we have all the ligaments, and we have changes in the blood supply and the innervation in the prostate sphincter. We have been doing some works with MRI, trying to identify the group of patients with more chance to have the sphincter insufficiency. Improves in surgical techniques like the dissection of neurovascular bundle, like dissection and preservation of the sphincters, they have resulted in improving incontinence. But why patients with preservation has a better outcome? It's because of the preservation or because the surgical technique is more adequate. We have some papers trying to measure urethral length and urethral pressure. And every time that you have an increase in urethral length or in urethral pressure, you will have better continence results. The time to recover continence depends on the many adaptations that occurs after the surgery, like neurological reflex adaptation, regeneration, sphincter adaptation, and bladder adaptation. And this occurs after at least 6 weeks and much more after six months. You see the regeneration of urethral afferents. It starts at 6 weeks and will be defined at 6 months. One other important thing is the urethral seal. Sphincter has a urethral seal just 1 centimeter below the anastomosis. And every time that you have the surgical trauma, you have some fibrosis, you have a reduction in urethral coaptation, and this may result in incontinence. This is there are some papers measuring urethral compliance. Urethral compliance is reduced after radical prostatectomy, and they try to measure this by reduction in the maximum Q after catheter. You see, in normal urethra, 7 French catheter will not affect Qmax, but in patients with reduction of the compliance, this will do. So you may have some obstruction by the catheter due to reduced urethral compliance, and this means stenosis and fibrosis. There are many papers addressing this issue. Patients' incontinence have a reduction in urethral compliance. Another factor besides the sphincter is the bladder. There are many ganglia, sympathetic ganglia, just beneath the bladder bases, and usually they are affected by the surgery, and they may result in the trusor hyperactive, and this may contribute to incontinence. In conclusion, sphincter deficiency is the main cause. Sphincter muscle preservation, as well preservation of its irrigation and innervation and support minimize the problem. The trusor dysfunction and obstruction may contribute to the incontinence in many cases. Thank you very much for the attention.
Thank you very much, Flavio. I think you really pointed out how complex the male incontinence problem really is. And if we think that for many years, all the guidelines and all the ideas of treating male incontinence were taken from the female incontinence, which really works so much differently, that is the reason why we are so a little bit behind the female incontinence treatment. Are there questions from the floor?
Very interesting, as always. So my question is concerning the very first few months after the radical prostatectomy, because the majority of our problems is still in that period. So the majority of our patients are still incontinent at the catheter removal, and then they all improve. Can you share with us what is the current body of knowledge on the denervation and reinnervation of the bladder neck after radical prostatectomy?
Well, this is an important point, Irving. The denervation involves the lesion of the ganglion. So if the reinnervation occurs, it's going to take at least 6 months. So this is why we avoid to do any invasive procedure in this period. Some people believe that with the robot, you could preserve the innervation better, and the patients may recover the continence earlier. But the final numbers are still the same.
There is actually no evidence that the robot is doing anything better on a continence. We just presented this at the ICI this morning.
Maybe the robot reduced the time to recover, but after 6 months, I think it's always almost the same.
So, would you agree that that 6 months is the moment to make, let's say, the next decision? Some patients are dry really after a week or even earlier. Others take some time to recover. In the old days, we used to say we make
You said a year.
A year. This is what I was going to say. That 1 year is the cutoff. It was my hunch that actually even before robots and everything, that maybe 6 months would be the moment to make decisions. If a patient is still leaking like 4, 5, 6 pads, then decisions should be made towards some even invasive treatment.
Well, I think 5% of the patients will increase between 6 months and 1 year. So the treatment choice will depend very much on the patient anxiety. So if the patient is anxious, if he wears many pads a day, I think 6 months may be enough.
It's just like Heather told us, we have to see the whole patient, not only his pads.
Okay, thank you.
Questions?
I have a question to combine both these presentations. So let's say that we have a patient a year, that he disappeared after he was crying home in his misery with incontinence. He does not want to have, or let's make 2 years actually. He does not want to have surgery. And he tried the Google, we have a Google doctor now, we have a Google Kegel, which is the majority of our patients unfortunately get this, Google Kegel, so they Google the exercises, they try to do it. So what is the role for the physical therapy after, like years after the event that caused the incontinence? And what should be what is the base, like scientific base on this? So this is a question for both of you.
Well, we have a controlled trial using physical therapy, and it improved the results in terms of continence, different from many other trials. I rarely use physical therapy after 1 year, but if the patient has some kind of hyperactive, I think it can improve it, but after 1 year, I do urodynamics, and usually I propose a surgery.
From a physical therapy standpoint of view, I think it's always worth your time and the patient's time to send the patient in for an evaluation, because at that time, I can establish, are they doing their pelvic floor contraction correctly? If they're not, do we need to modify it? You know, how is the patient practicing at home? Sometimes they'll say, yeah, I'm doing them. And one of my patients says, yeah, I'm doing 10 a day. And I'm like, well, if we're looking for true strengthening, 10 a day isn't going to do it. So we need to, when you look at recovery from stroke, research has shown that how do you get return of function? It's by doing multiple amounts. So at that point, it's also our job looking at the patient head to toe. Is the patient compensating in other ways? Or what other muscles could be factoring into their progress here. So I think it's always worth the time to have the evaluation to see if they need a tune-up sometimes too.
Can I just continue on the question? So there is an evidence that patients who were dry, let's say a year or 2 years after surgery, 5 years or 10 years after the surgery, we start seeing incontinence coming back. So what is the option for this, and what is the reasoning for this? Is that still a good option to go to the physical therapy for them? And why are becoming incontinent so lately after the surgery?
Well, the reason for them to become incontinent is the sphincter apoptosis. We have seen many patients as the patients are surviving for more time. And but I have no experience with physical therapy in this group. Maybe.
Let me also ask in this moment: is there a difference how you assess those patients who come later on, and the ones that you see immediately after prostatectomy?
How we assess them? Yeah. Mm-hmm. I think in general, I assess everybody. I tell them I start by looking at how they're walking, and then I'll look at abdominally, I'll look at the pelvis, I'll check the muscles in and around the hips of the pelvis, and then I'll do a rectal exam. I think that depending how soon they come to me after surgery, I usually will ask them not to give max effort on their contraction. If it's years later, I will ask for a max contraction but also see if they're compensating with that. If they are compensating, then I'll bring it down to 50%. So that's the main difference. But in that 10, 20 years, have they gained weight? You know, what other things have happened? What other comorbidities have they developed? And how can that affect muscle tissue, their lifestyle, et cetera?
Thank you. Any more questions? Thank you. Then we proceed to the next lecture.